Good morning, all of you. Myself, Dr. Pooja. Today's presentation topic over the panniculitis. So, what is panniculitis? It is an inflammatory disease which involves a group of disorders and basically involves the subcutaneous fat. Coming up, the panniculitis classification is broadly classified into the predominantly septal panniculitis and predominantly lobular panniculitis, and depending upon whether the vessels are involved or not, it is further divided into with vasculitis and without vasculitis. Septal panniculitis with vasculitis, whether the arteries involved or the veins involved. When the arteries involved, it's a cutaneous polyarteritis nodosa vein, and vein involves superficial maculatory thrombophlebitis. Coming up, the septal panniculitis without vasculitis, depending upon the inflammatory infiltrates, whether it's a lymphocyte and plasma cells or the histocyte with the granulomatous formation. In the section of lymphocyte and plasma cell, if the granulomatous infiltrate is it, the entity is the deep porphyria, and without granulomatous infiltrate is a necrobiosis laponica. Coming up, the septal panniculitis without vasculitis, when the inflammatory infiltrate is rich in the histocyte, which forms the palisade granuloma. In the center of the palisade granuloma, whether it's a mucin, it's a subcutaneous granuloma annulare. And if it's a fibrin in the center of the palisade granuloma, it's a rheumatoid nodule. When the cholesterol cleft is rich in the center of the palisade granuloma, it's a necrobiotic xanthogranuloma. And when without mucin, without fibrin, without generated collagen, it's a erythema nodosum. Now the lobular panniculitis again is subdivided into with vasculitis and without vasculitis. The with vasculitis, whether small vessels are involved or the large vessels are involved. In the small vessels, erythema nodosum leprosum and erythema induratum. In the large vessels, arteries involved is a erythema induratum. Without vasculitis, lobular panniculitis, depending upon the inflammatory infiltrates, whether it's a few or no inflammatory cells, is a sclerosing panniculitis, calcific uremic arteriopathy. If the lymphocyte inflammatory infiltrate is rich, it comes under cold panniculitis, lupus panniculitis, and dermatomyositis associated panniculitis. Lobular panniculitis without vasculitis, when the neutrophils are rich, is the entities comes under it is the panniculitis alpha-1 antitrypsin deficiency panniculitis, infective panniculitis, factitious panniculitis, and subcutaneous sweet syndrome. Lobular panniculitis without vasculitis, when the histocytes are rich, the entities are the subcutaneous sarcoidosis, traumatic panniculitis, subcutaneous fat necrosis of newborns, scleroderma neonatorum, post-steroid panniculitis, gouty panniculitis, fungal panniculitis, mainly because of the Jaggomycosis, mycorrhizasis, aspergillosis, cytophasic histiocytic and subcutaneous T-cell like lymphoma, and the sclerosing post-radiation panniculitis. Coming up the details of the each entities, first is the erythema nodosum. When to suspect the erythema nodosum? When a female of the age group 20 to 30 years coming up with an acute episodic eruption of erythematous, tender, non-ulcerated nodules in the plaque situated bilaterally on the pre-tibial area, with the associated symptoms of the fever, malaise, and the arthralgia, and giving history of the past lesions which regresses spontaneously after persisting for the 3 to 6 weeks, and having no residual scarring from the previous lesion. And this picture showing the lesions of the erythema nodosum. Erythema nodosum basically considered to be hypersensitive cutaneous response of the underlying etiology, and majority of cases around 37 to 60% is idiopathic, and second most cause is the infection which corresponds to 20 to 30% is a streptococcal infection, upper respiratory tract infection. Other etiology of the erythema nodosum includes sarcoidosis, inflammatory bowel disease, in which the Crohn's is associated more than ulcerative colitis, and the various drugs including estrogen, oral contraceptive pills, bromides, iodide, sulfonamides, amoxicillin, penicillin, levofloxacin, minocycline, acetaminophen, ibuprofen, naproxen, carbamazepine, and phenytoin. Other entities include the neutrophilic dermatosis, Behçet's disease, and Sweet syndrome. Acne fulminans, including the acetylcholine induced in pregnancy, and the various other infections like the brucella, coccidioidomycosis, chlamydia, mycoplasma, histoplasma, hepatitis B, and mycoplasma. It also seen in the cases of the lupus erythematosus and the HIV COVID-19 infection. Malignancy associated is the acute myelogenous leukemia and the Hodgkin lymphoma. So when the patient of erythema nodosum coming in the COPD, various investigation need to be given that include complete blood count including ESR, CRP, anti-ASO titer, anti-DNase titers, throat swab cultures. This throat swab culture usually comes negative because by the time the cutaneous lesions appears, infections already subsided. Chest X-ray, tuberculin test, IGRA, urine analysis, stool culture, pregnancy test, and biopsy in case of the recurrent and the relapsing cases. So in the biopsy, basically, it is a prototypic septal panniculitis without vasculitis, in which the septa is involved, which is thickened and edematous and inflated with the inflammatory cells, which is located mainly at the junction of the septa and the lobular interface. The characteristic feature of the histopathological finding is a Mitchell's microgranuloma, which is a small, well-defined nodular aggregate of histiocyte around a central stellate or a banana-shaped cleft within the septa. Coming up the treatment part, conservative treatment include a bed rest with a leg elevation, compression, limit of physical exercise, and avoid prolonged standing. Basic treatment includes the identifying and treatment of the underlying disease, and the symptomatic treatment includes the NSAIDs, which includes indomethacin given the dose of the 100 to 150 mg only, naproxen 500 mg once daily. Potassium iodide, saturated solution of potassium iodide is given in the dose of 150 to 300 mg TDS in the water or the orange juice. Other treatments include the colchicine 0.6 to 1.2 mg BD, hydroxychloroquine 200 mg. In the third line of treatment include the adalimumab, etanercept, systemic corticosteroid, and thalidomide, cyclosporin, and dapsone. This systemic corticosteroid should be given after ruling out the infection. Coming up, the next entity is the erythema induratum and nodular vasculitis. What a clinical presentation of this case is a female of the age group 30 to 40 years presented with a chronic, persistent, painful erythematous to violaceous, ulcerated nodules and plaques over the calf with the scar of the previous heel regions and giving the history of the past or the present tuberculosis. So, erythema nodosum is erythema induratum. Why it occurs? It is considered to be type 4 hypersensitivity reaction or immune complex mediated vasculitis and is classically associated with the tuberculosis. The picture shows the lesions of erythema nodosum with the ulcerated nodules and the plaque over the skin. So, over the calf. So, when it is associated with tuberculosis, it is known as a Weijin's disease, and when it is a non-tuberculosis etiology, is known as erythema induratum or Whitfield. Non-tuberculous etiology includes infection which includes hepatitis C, nocardia infections, brucellosis, hepatitis B, chlamydophila pneumonia, BCG vaccination, and various drugs like the propylthiouracil, TNF antagonist, cobimetinib, verumafenib, and the malignancy, leukemia, lung adenocarcinoma. Miscellaneous causes include the chronic venous insufficiency, aortic valve stenosis, Crohn's disease, hypothyroidism, rheumatoid arthritis, and systemic lupus erythematosus. Erythema induratum is a prototype of predominantly the lobular panniculitis with vasculitis. This histopathological image shows the granulomatous infiltrate showing foamic histiocyte giant cells. Langerhans type giant cells is seen when the intense inflammation is there. Cages necrosis can be found in the center of the glomerulus infiltrate. Investigation of this case includes the CBC, ESR, CRP, chest X-ray, tuberculin test, IGRA, skin biopsy, and PCR, the skin specimen, and hepatitis C serology. Bed rest include the bed rest, as like the erythema nodosum bed rest. leg elevation, compression therapy, and one should ask to limit the physical exercise and avoid a prolonged standing. Basic treatment when it comes to with the related to the tuberculosis, anti-tuberculosis therapy should be given in the full course. For the non-tuberculous cases, it treated like the case of the as if of the erythema nodosum. Now the third entity is the lipodermatosclerosis. It presents as an overweight female of age above 40 years with chronic venous insufficiency presented with an indurator form plaque on the lower leg with the hyperpigmentation predominantly on the medial aspect over the medial malleolus with the history of the hypertension, diabetes and the thyroid. Lipodermatosclerosis usually has the two phase, acute phase and chronic phase. Acute phase present with a painful, poorly demarcated warm erythematous plaque. In the histological finding, there will be the mid-lobular ischemic fat necrosis and there will be sparse infiltrate and capillary congestion with the exudation of erythrocyte which leads to the hemocentrin deposition that causes hyperpigmentation. And dermatostasis changes in the form of the thickened wall of the capillaries can be seen at any phase of the dermatosclerosis. And lipodermatosclerosis is considered to be both septal and the lobular panniculitis. Chronic phase is clinically present as a sharply demarcated induration, wood-like consisting and sclerotic with a hyperpigmentation. The typical presentation given the name as the inverted champagne bottle of the polypill deformity. The characteristic feature of the histopathological finding in the chronic phase is the lipomembranous stage in which the adipocyte is completely replaced by the fibrotic tissue, and this lipomembranous changes is derived from the cell membrane of necrotic adipocyte, which is also the past positive. Investigation part of the lipodermatosclerosis include to check the chronic venous insufficiency, to evaluate the peripheral vascular diseases, which include the ankle brachial index and the color Doppler. Usually biopsy should be discouraged because of poor healing and the ulceration. One should take the biopsy from the edge of the lesion. Treatment includes the leg elevation and the consistent compression therapy. This forms the main line of treatment, and for the prevention part, weight reduction should be advised. Other treatments include anabolic steroid which has the fibrinolytic activity used in the early stages, danazole 100 mg BD for the 2 months, and oxandrolone which is used in the females because of less hyperandrogenic activity. Other treatment includes pentoxifylline, doxycycline and minocycline which has an anti-inflammatory and angiogenic property. Topical corticosteroid and intralesional triamcinolone can be given. Ultrasonic therapy which helps in resolving the hardness, tenderness and the erythema. And lastly, the surgical management which includes fasciotomy and the phlebectomy.